I'm Larry Seidman, delighted to be here. And I know it's getting late in the day and I've got to go fast. So I'm going to be, in contrast to a lot of the other talks, I'm going to go deeper into one area rather than broad and build really on the talks that Marianne and Bill gave. The work is funded mainly by NIMH, also by Foundation and the Commonwealth of Massachusetts. And I'm really going to be focusing on trying to tell you about a new way of thinking about psychotic disorders that's leading to new and earlier interventions, really a paradigm change. And I have no conflicts of interest to disclose. So what about the epidemiology of schizophrenia and other psychotic disorders? So first, we're talking about schizophrenia, schizoaffective disorder, bipolar disorder with psychotic features, and major depression with psychotic features. Now, first of all, schizophrenia occurs in all countries. It's occurred throughout recorded history, and the rates are relatively constant as far as we know across certainly the last 100 to 200 years, but the prevalence rates do vary in different parts of the world, in different cultures, in urban versus rural areas. But the overall lifetime prevalence is a little less than 1 in 100. So on one hand, it's relatively rare compared to the disorders that Bill was talking about, but very devastating. So it falls usually into the top 3 or 4 of the global burden of disease, of all illnesses. It's more common in males and females, and the typical age of onset for males is roughly 22, females 27. Peak ages are really in the young adult period, and this is pretty much true for the major affective psychoses, which total about 2% lifetime, and they also have a similar period of age of onset. This, in a way, is another way of showing a slide that Bill really showed. You know, in younger childhood, we've got the onset of learning and attentional disorders, anxiety disorders, but out here, pretty much between 15 and 30, and centered really between 20 and 30, just as people are becoming young adults and independent, is when their psychoses are most likely to begin. That probably has something to do with brain development as well as social and environmental factors. Now, what about symptoms, not just disorders or syndromes? So psychotic symptoms, it turns out if you interview carefully, it turns out that more like 5 to 15% of children and adolescents will report some kind of psychotic symptom. They may be healthy and they may have had odd experiences, and these are not always or often even attributable to drugs. It's just that we're beginning to learn more about maybe the more extreme aspects of mental processes being more common than we previously thought. So even though they don't always predict a psychotic syndrome or illness, you do need to pay attention to it. And the focus is really going much more to late childhood and early teen years. And we also know that social and neurocognitive impairments are frequently present from childhood on. And this is fairly typical of what you might hear when you interview someone. In Ellen Sacks's book called The Center Cannot Hold, Ellen Sacks has schizophrenia. She's a law professor at USC, and she's written a beautiful book about really the world that she lived in and when her symptoms began around age 7. But what you can see here I'm saying is the border of psychosis, which we're linking to a rating scale where a 6, a loss of reality testing and a loss of insight. But there may be a waxing and waning and a kind of cascade, a kind of crescendo of symptoms that may be emerging over time that ultimately results in a full-blown psychotic disorder. What that tells us is maybe we have an earlier intervention opportunity if we can pay attention to these kind of brewing symptoms. And this is another way to look at it. This is a slide from my colleague Macheri Keshavan and Barbara Kornblatt. And what it suggests when you look backwards at people who develop schizophrenia what you see, often the first signs in childhood are cognitive, attentional problems. Roughly 40 to 50% of children who later develop schizophrenia have some cognitive problems that look a little like ADHD. They may later on, and this path is not a sort of inexorable one, but this may be a prototypical one where other symptoms begin to emerge: withdrawal, daydreaming, perhaps normal childhood behaviors, but in the extreme, but more social difficulties, which later in the teen years start to really impair social and role functioning. Attenuated positive symptoms, sort of mild symptoms, may be the first expression that really heralds more likely a psychotic disorder, and we're going to come to that. So when we've thought about schizophrenia for the last 100 years, we've tended to think about this. We've thought about it's inexorable, there's nothing you can do. That view is really wrong and outmoded. And it's certainly true that many people will have a chronic and severe course. But we're learning much more about this phase, which is the period of decline, so-called clinical high risk or prodromal period, as well as the so-called premorbid period. Here, we don't yet have good tools for identification. Here, we actually are starting to. But what I want to call your attention to, if we don't intervene early, what you get is something like this. This is a review, meta-analysis by Diana Perkins, 1 to 2 years on average of having a duration of untreated psychotic symptoms. Sitting in your room, withdrawal, fighting the demons in your head, not telling anybody, but something then happens and you end up in the hospital, which of course is a late stage of the illness and a very bad outcome. So what do we know? This is just a brief smattering of data to show that, for example, in first episode patients, earlier treatment leads to better outcomes, and this is with antipsychotic drugs, although other treatments, psychosocial treatments, may be better earlier. The time to remission is a function of the prior untreated duration of psychosis. So again, shorten the DUP, which countries such as Norway, Sweden, Denmark have done by having widespread public education and early intervention programs, may lead to a better outcome. And if you can do very intensive kind of treatments, you may prevent some of the worst outcomes associated with the illness, including significant brain changes. Now, one of the things that we're focused on a lot lately, because of rare but very extreme cases, are cases of violence with psychosis. And whether it's at Virginia Tech, Loeffner, Holmes, these are people, again, very atypical for schizophrenia, but there is a bit of a pattern that's worth paying attention to, because we have to walk a very careful line between stigmatizing a whole group of people incorrectly, but recognizing that the untreated phase of the first episode is a dangerous period. And what I want to call your attention to is that, maybe on the next slide, that basically the rate of violence, including homicide, is 15 times higher in people in the first episode when they're untreated compared to treated. So again, another reason why it's critical to have early intervention. Yeah, that's this data here. There are a variety of things that predict violence, but certainly the duration of untreated psychosis and the lack of treatment are probably the single biggest factors that are going to put people at more risk for that unlikely but severe outcome. So what can we do? Well, first of all, mental health literacy about this is very low, and I think that's why I took this kind of point maybe for this audience. We can now educate the community in a variety of ways, and we find that young people get a lot of their health information from the internet. So we have websites where they can go online because they themselves may be worried about, am I going crazy? Am I losing my mind? And is there a place, is there somebody who I can talk to about it? And there are now instruments, so structured instruments that can be used to diagnose this so-called clinical high-risk period before the psychosis begins, but when it's clearly brewing. And that during that period, we already know, this is measures of IQ, but IQ is only better studied than many other measures of cognition. We could take memory, executive function. We just don't have good measures at all phase. But during the premorbid period, on average, there's already cognitive impairment, even though some people are brilliant up here and some people are more limited down here. During the so-called prodromal or clinical high-risk phase, cognition is more impaired, and it's more impaired by the first episode, where you can see the first episode and chronic are almost the same. So most of the variance is accounted for before the frank psychotic illness. And that implies we need to get in there earlier because it's the cognitive impairments that are most associated with disability in life for people with schizophrenia. It's not the hallucinations or the delusions. It's the ability to reason, remember, pay attention, so on. Here's some other data that's relevant to this sort of evolution in the clinical high-risk period, which is based on cortisol. This is in a paper in Biological Psychiatry now, which just shows that people in the psychotic phase have the highest cortisol levels. In the so-called clinical high-risk phase, they're intermediate. When they remit, they're back to normal. So cortisol is a stress hormone. Stress really does matter. And that's another thing that we can intervene on. A person may be vulnerable, but may not go on to develop a psychosis if we have the proper interventions. Now, this just shows you a paper published in the Archives of General Psychiatry showing that when this is from the so-called North American Prodrome Longitudinal Studies network, we interviewed about 800 people, around 300 were considered in this clinical high-risk period. When we followed them, roughly 35% by 2.5 years developed psychosis. So this tool is by far the best tool that we have developed certainly in the history of psychotic disorders for identifying people and predicting an outcome. Of course, there are many false positives, 65%, but out of those 100% of people, 1/3 develop psychosis, another third continue to have significant disability, and some remit. So we have to be careful about stigmatizing, but many people are suffering, and these are treatment-seeking people. So there is some research now. There's a meta-analysis that reviews different types of approaches. There's no one standard of care yet. There are some studies of antipsychotic medications, which on the whole, we think should be used late in this clinical high-risk period, that treatments like cognitive behavior therapy, family therapy. There's one very promising study using omega-3, which works on membranes at the cellular level and alters processes like oxidative stress and other things that may trigger negative things going on in the brain at the synapse level that lead to psychosis. So far, the results are promising and suggestive in that in the meta-analyses, about 30% of people in the clinical high-risk period go on to develop psychosis, but in these treatment studies, only 10% do. And that's a significant difference. So there's a beginning sense that we could actually prevent psychosis and certainly reduce disability. So, of course, the first 5 years of illness are the most serious period. That's when the decline may be maximum. Again, some of the more severe outcomes that gather more attention that are pretty rare. So we think this is a critical period for effective intervention, and a number of things could be done to address this. I'm going to skip this slide because I think I've covered it. I want to summarize a few points. What are the barriers to care so far? So first of all, denial and on the part of the patient and the family, and stigma. there's a poor recognition of symptoms by others before very late in the disorder. We tend to ignore what's going on. This is poor mental health literacy, limited knowledge on the part of mental health providers. In other words, there's really limited expertise in our field. A lack of access to treatment, very limited trained workforce and very limited services for this phase, and very few programs in the United States, roughly 10 to 15, whereas around the world, for example, in the UK, there are 50 to 100 programs of this type in a country with 1/5 the population. Marianne mentioned the child-adult chasm. These are people basically between the ages of 14, 15, and 25. And of course, the society needs to have a financial buy-in for early intervention, which has certainly not been the main issue. So just to quickly summarize, psychotic illnesses begin in their teens and 20s, and mental health services tend to intervene late. So there's a service gap also documented previously during adolescence. The need for care well precedes a psychotic diagnosis. And of course, hospitalization is a very late event, can be traumatic, maybe life-saving and important, but certainly can, if we can avert a hospitalization with earlier treatment, that would help, and we would try and intervene in that earlier psychosis phase. The better prognosis with earlier intervention so far. And we're starting to be able to get better tools to figure out who may be going on to develop psychosis. That's obviously a big area of research and looking at the cost-benefit analyses. And let me just, this is my last slide, just to show you one system that we've been working on at the Beth Israel Deaconess Medical Center and Mass Mental Health Center in Boston, where we have fought tooth and nail with various donors and the state to develop a first episode and clinical high-risk program. We work a lot with the colleges and universities. We do a lot of public education, give probably 100 talks a year in the community about this, and do research and training. So I better stop here. Thank you.